Well, good afternoon, everybody. Welcome to today's Trust Board meeting, and just about okay, I think, to say Happy New Year to everybody as well. And I hope that you got a bit of break and relaxation over the Christmas period, although, as we'll be hearing from Matthew in a bit, it's been pretty busy in the Trust, as you could imagine. We're going to start today, before we move on to the formalities, with our patient story. So, Victoria, would you like to introduce Rick? And Rick, you're very welcome, and thank you very much for coming to talk to us today. Victoria.
Absolutely, no problem.
Certainly, thank you, Chair. So yeah, Rick has already introduced himself to those that were on the call just before we started. Rick Harris. So he is, we agreed to say 40-something man. Works for Department of Work and Pensions, and he lives in Cambridge, but he is from this area. His mother lives in Haldwood, and he's going to talk about what happened to him in early January 2020. When he was house sitting for his mother and he needed to come into hospital. So on that note, I'll hand over to you, Rick, to tell your story, and then at the end, if there's any questions from the board, that they will ask.
Okay, can I just ask, just to manage expectation, how big's my slot?
We normally say 5 to 10 minutes, if that's okay.
Yeah. No, if I'm waffling, please someone put their hand up and tell me to stop. But basically, the story is probably a very similar one to a lot of people have heard. As I'm a guy, I refuse to believe there was anything wrong with me. January the 14th, 2020, I started getting what I would consider indigestion, heartburn. It lasted a long while. And as I say it, I feel stupid for not actually deciding that it was something more serious. I was getting out of breath. I couldn't walk very far. My jaw started aching. Or any website that I put those symptoms into, it come up red and told me to phone 999. But I historically have been very scared of hospitals. Me and my GP don't know each other. I haven't been to a hospital in 20 plus years. So basically, I tried to tough it out. 2 weeks went by, and with the family having a go at me saying, look, you need to go to the doctor, you need to get it checked out, there's something not right. I was recovering, I felt better, but I wasn't recovering anywhere near the rate you normally do after something little. So in the back of my mind, I had a feeling it was something serious. So when I house sat for mum 2 weeks later, which is my family home, I thought, you know what, I'll pop and see the doctor because it's only just around the corner. So I went and saw my GP, explained the situation to him. He didn't seem overly concerned, which is odd. He didn't check my blood pressure or anything like that. He just suggested that if I was still worried about it, I should pop along to A&E. It was late in the day, so I decided to wait until the next day and go to A&E. So I did. I drove myself to A&E on Friday, the Friday of that week. So this is 2 weeks after the incident. Explained what had happened, and I was in A&E standing up waiting to be seen, no more than 15-20 minutes. For someone that hasn't been to hospital for some time and hears horror stories everywhere, I fully expected to be there all day in A&E, but I was seen within 15 minutes, and I didn't even get a chance to sit down after I'd been triaged. I got basically taken out and taken into a little area where I had a blood test, but unfortunately the nurse that put the cannula, can't even speak, the cannula in my arm, I passed out because I'm not good with blood, I'm not good with needles, hence me not going to a doctor for many years. So they did the blood test, and over the course of the next couple of hours told me that there's the heart gives off a chemical when it's in distress. They took a reading of that level and it was over 130, which indicated that I had had a heart attack. So they admitted me there and then. They kept me because they wanted to put me on the critical care unit, but there was no beds available. So they put me in I think it's the ERU, which is, I suppose, because of my age, which upset me a little bit because they put me with a load of old people. But I think young people would call me old. So, it is what it is. I was in there for 3 days, being seen by various different specialists, had different tests while I was there as well, where I was told that I would need, I needed to go to BHRUT to have, I think it was the dye thing to see if I can't, I mean, it's 2 years ago, and I'm one of these that don't want to know what they're doing to me, just do it, because if you tell me what you're doing, I won't want it done. So they had to do something, and apparently if they decide at the time I would need a stent, they would put it in at the time because they would be in a position to, which absolutely scared me stupid. If my other half was on the call, she would tell you that I very nearly walked out of the hospital at that point, which would have been really stupid. And you know, it was only my other half and my sanity, I suppose, telling me, look, you need to go through this, otherwise you're not going to last much longer. So they took me to BHRUT a couple of days later. I had the stent put in, returned me to BHRUT, to Queen's for the recovery. What I want to say is, between going in the ERU to the CCU, it was, you know, the CCU was incredible. I would have sworn that I was private. It was absolutely amazing, how I was made to feel at ease. You know, I was very, very nervous, very, very anxious about just everything that was going on. The guys in the CCU were just absolutely fantastic. I could not have asked for more from them. They were there to answer any questions. Nothing was too much trouble. Even though when I was admitted to CCU, it was like 2 o'clock in the morning. They asked me if I wanted any food or a cup of tea, or, you know, right out. They went above and beyond just to make me feel welcome. So yeah, my overall experience of the whole thing, you know, bearing in mind I can't stand hospitals, they scare me stupid. It was a very, very positive experience for me, and would just like to take this opportunity to thank everybody involved in the CCU unit and you guys at large, please.
Rick, thank you very much for that, and for being so sort of straightforward in the way in which you described it. This is an opportunity for my colleagues to ask any questions if you're happy to receive them.
Absolutely.
And I have a question as well. First, it's interesting, Rick, that you talked about not wanting to accept that you might have a problem, and therefore not seeking help earlier. Is there anything that you think that we or the broader health system could do to help people to sort of overcome that reluctance, or to make people more likely to seek help earlier? Because obviously if you can, that would have been better, wouldn't it?
Absolutely. I think when you're a guy, let's just generalize, when you're a guy, any kind of validation of how you're thinking, no matter how crazy, allows you to get away with it in your head. I think they call that man math, you know, when they explain why a more expensive and faster car is obviously the choice for the family. It's a lot of it was my understanding of a heart attack was a pain in the chest, a pain in the arm. I didn't have a pain in my arm. I wasn't aware until afterwards, and chatting to people and researching, that the jaw was, I mean, when I was having my stent put in, which incidentally was the scariest time of my life, and I don't think I'll ever be that scared again, because I had to be awake while they were doing it. Did not enjoy that. But at the time when they were putting the thing in, they said you are going to feel a feeling similar to when you had the heart attack, when they were pushing something through, and my jaw went all funny again. So it's obviously something that's connected and well understood to be connected, but yet we see the posters and we see the publicity that it's arm and chest. There's no mention of the jaw. And I think if I'd have known about the jaw, I mean, it's my own fault. I've got the internet, I could research stuff like that. But I think if it was more commonly known, I wouldn't have been able to talk myself down from doing what I knew was right, if that makes sense.
Thank you. Yeah. Mahboob.
Yeah. Thanks, Rick. That was really interesting hearing what you had to say, and kind of Jackie has alluded to what I was going to ask you around there, in that, like you, I'm a bloke, and unless my leg drops off, then I'm absolutely fine. I keep on telling everyone. Would you, two questions. One is, please do give us any areas for improvement. You know, the service is as fantastic as you've said. That's brilliant to hear. But if we could improve something, what would you want us to improve? And then secondly, Rick Harris, who works for the DWP, would you be willing to take part in any sort of promotional material to get these messages across to other men of our age, if I can relate to you in that way? It'd be really helpful, because I mean, a lot of people just ignore those messages until they're too late, and particularly during a pandemic when people are less reluctant to access health services when they need them.
Absolutely. So for the second question first, yes, depending on what it is. Absolutely, anything that can help others, I'm down for. I spend my life helping others in my job, and cooking for a neighbour who's recently lost his wife, etc., etc. So yeah, absolutely, if I can. There might be a limit to what I'm prepared to do, but yes, by all means, talk any options through with me. Anything you could do better? It's funny. I think a targeted campaign, maybe. Actually looking at the demographic of the people who are least likely to look for help, which I think I lay squarely in that demographic. I class myself as an ordinary guy, which basically means I have no protected rights whatsoever. But yeah, something that focuses on, look, it's not big and it's not clever to hide a condition which you will pay for later on in life. I remember the doctor saying something to me which really stuck in my mind. I can't remember which doctor it was, but he said, you can either have a few years of discomfort now or spend your whole retirement in pain. Talking about improving your lifestyle and stuff. There was incidents in my life leading up to not just part of my problem was hereditary, and another part was drug abuse from years ago when I was a wayward lad. And I think, excuse me, that you take it for granted what you eat. You don't look at labels. You don't do this. You don't do that. You just don't realize what you're doing to your body. You think, oh, it's okay. It's just, it's just sugar. It's just salt. But, just eating just a little bit more carefully. I know there's tons of things around that, but I think you need people that have been through it to talk about it almost, because it just goes in one ear and out the other with all the rest of the, you must do this, you can't do that, you shouldn't be doing this. A lot of it is unachievable. 5 a day and stuff is difficult, but I think if you can't have 5 a day, you don't bother having any a day. But so let's just say, look, 1 a day is better than none a day, or something, just something to try and steer people to just making the smallest of change, which will have the big impact later on in life.
Lorraine, although you're not formally a member of the board, I'll let you ask a question on this, and perhaps you'd like to introduce yourself as you ask it, Lorraine.
Thank you very much. So I'm Lorraine Silver. I've been around quite a few years. Victoria will attest to that. Having sat on the BHRUT patient panel many years ago. I chair my PPG. I'm also a director of Healthwatch Redbridge. I chair the board there. And I'm an ex-medical secretary from Barts Health many years ago. So, Rick, I understand exactly where you're coming from, because 2.5 years ago, my husband collapsed with pneumonia and was rushed into King George Hospital and was well looked after and recovered, and did not tell me that he was feeling unwell. And I think this is the issue. I've seen it so many times, as you've said, that men tend to keep so much inside and don't even tell their other half. So education, I think, is the key, and listening to people, like yourself, about your experiences. I don't know whether the PPGs at GP surgeries can maybe be a part of this, by trying to, educate. And I don't think it's just men.
Right.
There are women. So what would you think about doing getting involved maybe with PPGs from your surgery to try and give more awareness?
I don't actually understand what that would entail, but yes is the short answer.
Brilliant. Lorraine, perhaps it's something, because I know we're meeting formally in your role as Health Watch Chair in a few weeks, so perhaps it's something we can pursue there. And obviously, Rick, I think you're going to be in demand for your story from the sound of it after today. Okay, let's move on to Caroline.
Thanks, Rick, for sharing your story. I think, you know, whenever we visit a hospital or have some kind of procedure or operation, anything like that, there's one abiding memory that comes out of it. It could be the surgeon saying, this is going to be a nasty, sharp sting, and feeling that you're being attacked by an Asian hornet, or perhaps that's just me. Out of your visit on this occasion, do you have one particular abiding memory?
Yes, and it's going to be very odd. The nurse, when I was rolled into CCU, she rubbed my toe. My feet were sticking out the end of the bed, and she just rubbed my toe and looked at me and just said, "We'll look after you." And it's just such an odd thing. I haven't got a foot fetish or anything. Don't worry. It was just it struck me as it was a real personable moment. You know, she didn't need to do that. That wouldn't be in any of your procedures. Well, I hope not anyway. So it just instantly brought me from my highest anxiety level straight down to just these, you know, I'm going to be okay here. So it's just the little things, honestly. You can say all you want, but actions definitely do speak louder than words.
That's a really powerful example, Rick, that I'm sure we will want to share more widely with our nursing staff, but thank you for that.
No problem.
Joan.
Yeah, I'm not going to say too much more, Rick. I can see a headline already that says a nurse who rubbed patients' toe, you know, and people just having a smile. I think what you're bringing is the humor as well as the seriousness. So there's nothing like a local person giving a local message that you've given, and just really appreciate that you've come and told us that today, and hopefully we can work with you and your, what did you call yourself, ordinary guy face humor. It just would bring so much assurance actually to people. So thank you.
That's all right. I know people mention that I live in Cambridge. I own my family house, and so I spent 35 odd years of my life in Harold Hill, and I'm down there at least twice a week seeing mum and stuff. So, you know, I have big roots there, and more than happy to represent as you know. Depending on what it is, please don't have me standing on top of a tour bus with a loudspeaker or anything like that. Sorry, Victoria, I know that's ruined your plans for the next 2 months.
Okay. Last question is from Ruth.
Hi, Rick. So, I'm a GP in Upminster, so I'm coming from a slightly different angle. Interestingly, from your story, I actually took I feel you're a bit let down from a primary GP care point of view. And part of my job is prevention rather than cure. So I'm sorry that you even got to the point that you got to of needing to go to hospital and being in a position with your heart. So looking back now, I mean, obviously you've been through what you've been through, almost forgetting that. What could have got you through the door at a GP surgery just to do your simple health check? So your bloods, your blood pressure.
Maybe I mean, I've said this for a long while, but I don't know how practical it is for you guys, but you know, like you have an MOT on a car, you know, like our ladies have smear tests and stuff. I don't know how feasible. I mean, that's something I would pay for. You know, I would pay £45 to come into a GP surgery.
So we offer that actually. So 40 to 74-year-olds all can have a health check every 5 years, full bloods and examination. I think for us, it's trying to get hold of people and bring them to see it's important. I think it's something we need to work at, though. I might pick your brains another time to see how you think you did, like a letter, text, whatever it could have been.
Yeah, I mean, yeah, absolutely. I'm more than happy to open any kind of dialogue as far as that goes. I've worked in data analysis and stuff in the past, so you know, targeted campaigns and crunching data to get, you know, all of that kind of stuff is kind of my background anyway. So happy to butt heads, no problem at all. Anyone, if you need my contact details, Victoria, I'm more than happy for you to share So just speak to Victoria.
Rick, thank you very much indeed for that. As you can see, people have been very grateful, and I think you've provided some really important sort of context and colour in terms of your experience, and I'm sure people will be following up with you as well. So thank you in advance for that, and thank you for attending our board meeting today.
Thank you all guys for being so friendly.
They are a friendly bunch, you're right.
Not what I was expecting at all. Thank you very much, guys. All right, see you all later.
Bye-bye.
Bye-bye.
Thank you. Good. Okay, so let's move on then to the business of the meeting. And first of all, in terms of apologies for absence, we've got Leslie, Siri, and we've got Alex Hamilton. Apologies. I don't know, Linda, have we got any others that have been reported since you told me about those?
No, we haven't.
No, okay, great. Item number 4, we've got the Board of Directors declarations of interest, which is simply an update to my records, because I forgot I was the chair of BARTS at the point at which I filled it in. It's the most obvious things you leave out of forms like that, but that's now included in the public declaration. Does anybody have any conflicts relating to anything on the agenda today that they need to identify at this point? No, okay, good. Let's go on to the minutes then of the previous public board meeting that was held on the 9th of November. And I will go through them a page at a time, so that we can do any corrections if necessary, and we can pick up any points if there are any that people want to raise at that point. So I'll try and go at a speed that will enable you to put your hand up if you want to. So page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, page 13, page 14, where a typo in 22.1 I think has now been corrected, and page 15. Lovely. Okay, there was one item on the action log which is due to be reported in the March board report, so that's still in progress at the moment. We've also, just to go back a stage, I'm sorry I missed Anthony at the point of the apologies. He's offering half apologies because he's between graduation ceremonies for the university and he'll have to leave early. Thank you for that, Anthony, and thank you for coming, because I know that's a busy time when you're doing those graduation ceremonies. Okay, let's move on then to, we've done Matters Arising, we've done the action tracker. So my report under emerging issues, just a few things to report on since we last met. The first is we were able in December to publish an update on progress with the collaboration that was circulated to board members and is on our website, and that I was able to update the joint Outer North East London Overview and Scrutiny Committee on. And positively, it's identified some sort of practical areas where we're seeing some benefits from the collaboration already. The 1,500 patients who've been able to come from BHRUTs to receive treatment, both diagnostic and a small number of procedures that we've been able to provide for them, obviously as part of helping to bring down the backlog. As we know, the support that we're receiving, very practical support that we're receiving from BHRUTs clinicians, particularly in terms of our urgent and emergency care. Some of the work that we're doing on workforce across the two trusts, which is important in a whole range of ways, and not least, of course, to help us, as we'll see later, with our financial position in terms of managing our bank and agency staff better. And the collaboration update also linked to the memorandum of understanding that we had agreed as a board, and which has put in place some of the sort of structure for ensuring that we're continuing to make progress on delivering results from the collaboration, and we'll have more that we'll be able to say about that in future meetings. I've touched on the fact that we, and this is in the stakeholder report in the private board as well, I was able to attend the joint overview and scrutiny committee. I was able to meet with Linda van den Hende after trying to shut her out of last meeting. We had a very good meeting where we talked about the patient engagement work, and I'll be going along to talk more closely to her team and to the committee at a future time. We had, I was able to go with Matthew and with the surgical team at King George's on the trip that Professor Neil Mortensen from the Royal College of Surgeons came on. He was enormously impressed with the work that was going on there. I met with Carolyn Botfield, who's responsible across the system for estates, and talked in particular about some of the considerable challenges that, of course, we'll be facing in this area from population growth, and the way that we will need to think about how we're using all of the estate across the health system. I met with CCG chairs as well, all GPs, but in their role as CCG chairs. And on Thursday, Matthew and I will be visiting a local GP practice, both to talk and to listen, but also as an important sign of demonstrating our understanding of the pressure that is being faced all across the system, particularly in primary care and by our GP colleagues, and to make sure that we're working as closely as possible as we can together in order to recognise that, and to thank them for their efforts as well on behalf of our patients across the system. The final thing, I suppose it's just worthwhile noting, is people will probably have seen that the legislation that will create the statutory ICS, because of the speed of its progress, the decision has now been made by the government to put off the date for the statutory nature of the ICS until July. But in North East London, the plan is to continue working on the arrangement for the new structures and the new governance, and for that to be in place by April and to run in shadow form from April until July, which seems like a sensible way of making sure that we've got time to both get used to the way in which that works and to make sure that it's embedded properly. And I don't know if I reported at the last meeting, possibly not, but it's been agreed that I will sit on the Integrated Care Board as a chair representative of the acute sector, and John Geeve, the chair at the Homerton, and I have agreed that, and we'll be working together to make sure that there's a common representation of our views and our interests and concerns at that board, as well as, of course, working for the good of the system as a whole. So that's my update. Does anybody have any questions on that before we move on to Matthew? Okay, good. Matthew, Chief Executive's report.
Thanks very much, Jackie. Hello, everyone. Hope you're all well. So a couple of things to update you on. First and foremost, you'll have seen plenty in the press about the pressures that the latest wave of COVID has been causing across the NHS. I think it's only been about 6 weeks since the first cases of Omicron were detected. What we've had is is a challenge in 6 weeks, but I think it's worth emphasising COVID's been a significant part of the challenge, but not the whole challenge. You know, there's been a lot of the usual winter pressures we've seen across our 2 hospitals. At the minute, we do have in excess of 200 positive COVID inpatients, but those numbers are looking as if they've plateaued and are due in the last couple of days seem to be heading in the right direction. And of those 200 plus across the sites, a significant number of those patients are what's been called incidental COVID. So they've been treated for other things in addition to COVID. Our use of oxygen, for example, has been down significantly on 12 months ago. And what we've seen is that removal of that very clear link between the case numbers that are published, the numbers coming into hospitals, and the number of really critically unwell patients. And what we've certainly seen across North East London is that the vast majority of people who are ending up in intensive care are people who haven't had the vaccination. And as a result, what we've seen is a really quite different profile in terms of clinical severity according to those kind of numbers that we'd have seen a year ago. One of the bigger challenges actually potentially than actually managing the clinical COVID cases has been the effect that infection prevention measures across the hospital have had on that, because we're dealing with a COVID and a non-COVID inpatient population. The unknown status of patients coming through the front door, actually, and managing that and trying to do that in a safe way has meant that managing all of our pathways has been challenging and quite difficult. So thanks to all the teams who've been working flat out to make the most of that, you know. But you get these circumstances, if you've got a bay of 4 beds and 1 empty bed and the other 3 patients there have got COVID, you can't put a non-COVID patient in there. And in previous winters where we'd perhaps have used surgical wards for medical patients to reduce pressure on ED, we can't do that now. So we've lost some of that fluidity and flexibility in the site because of infection prevention and control. And as a result, that's made the last couple of weeks particularly difficult. But I have to say, talking to teams on the ground, you know, they've said it's not in many respects been any notably worse than perhaps 2 years ago in terms of volumes, challenges, etc., except for that loss of flexibility about how we manage things. We've also had issues, of course, as well with slower discharges because colleagues working in care homes and other sectors, community, etc., have also had to deal with COVID. And indeed, staff sickness has been a really significant issue for us. Now, in the run-up to Christmas, I think there was fears that we'd be looking at potentially a 30% sickness rates, and that was what some of the modelling and planning was based on. Ours has peaked so far at around 6.9%, and in fact today is back down below 5% in terms of staff sickness, so that's well short of the 30% we'd feared. Still enough to make things difficult, and we've seen a lot of flexibility. Teams like critical care and ED in particular are hard hit, and I know a number of folk in those teams were very good at picking up the phone to colleagues, and when they received those calls for coming in when they were off shift to help out, make sure that we kept services going safely. So thanks very much to all the staff across both sites who've really pulled out the stops to keep things going. And in fact, we've had some additional support arrive this week in the shape of 9 military staff who are deployed partly in intensive care and across the rest of the trust to help us out as well. So if you see them wandering around in their uniforms, do say hello and make them welcome. And at this time of year, anyone who can come in and lend that kind of skilled expert support to the trust is extremely welcome. We've got beds opening up as part of our winter plans. We've not had to do anything that wasn't in our initial set of winter planning. You know, as a result of us seeing these lower numbers of particularly sick COVID patients than we'd feared. So that's been positive. But we've opened 15 beds at King George this week, Erica Ward, and we're just getting the first 10 of those beds into use over the last 48 hours or so. Next week, North East London Foundation Trust are opening a stroke rehab ward, Daisy Ward, at the Goodmay site, which has got the capacity for 15 stroke rehab patients. For staffing reasons, it'll initially be open to 10, but that'll take 10 patients out of our stroke ward and give us those 10 beds here on the Queen's site. And then in February, once the critical care build here is complete, we've got Sky A, which is a 30-bedded ward, which will be available to us. Again, because of staffing constraints, it looks as though we'll be able to open 10 beds there initially. But what we'll see then is the 15 in Erica, the 10 on Daisy and the 10 in Sky A. So we've got the capacity there for up to 60 additional beds. But initially, we're looking at somewhere between 30 and 35 of them being in play because of staffing challenges. So it is great news and a great relief that the vaccine and prior infection has been so effective in reducing severity, and that's allowed us, I think, just to hold the course through the last couple of weeks in what's been quite a tricky period. So I'll just finish off by talking a bit more about vaccinations then, because you'll have noticed, I think, from The press and also in the papers, I've included my letter to a significant number of our staff who've not yet had their vaccination. Regulations have now passed through Parliament, I think, to make it mandatory that from the 1st of April, people working in regulated services need to have had 2 doses of the COVID vaccination. In practical terms, that means people need to have had the first dose by the 3rd of February. And the scope is wide, and it does, if you read through all the guidance and regulations that we've currently got, it does largely include anyone who works on a hospital or clinical site, because they will be going into common areas where there'll be patients. So you can see from the letter I've included there that this is going to affect the majority of our staff, significant number of staff. There is more NHS England guidance due, but it's not due till the end of this week. And I think because we've literally got 3 weeks before we reach that February 3rd deadline, we decided to push on with our communication with staff. At the minute, of our 7,500 staff, so we've got about 7,550 staff on the books, we've got 1,300 who we don't have a vaccination recorded against. So that's about 17.4%, where we don't have it recorded that they've received their first or second dose of their booster. The particular areas of concern we've got are in women's and children's health, in geriatric services and ED, and also a significant number in our clinical support services. And the highest number of vaccinations, and perhaps unsurprisingly, is in intensive care. Well, you would expect that staff group to have been very focused on that. So we're in a position here where we're about 3 weeks away from a position where it's part of people's contracts that they need to have had the vaccination. Now, of that 1,300 or so who we don't have a vaccination recorded against, we're pretty sure that a significant number of those may have had vaccines elsewhere. We're also hopeful that a number of those will decide to have their first vaccination in the next couple of weeks. And between yesterday and today, the numbers have improved by 58 there, and we're seeing that increasing. But we're also aware that there is a small but significant group of staff who've got very strong views on this. I'm going to meet some of them later this week to talk about their concerns, recognising this isn't a trust policy or an NHS policy. This is the law. This is been passed by Parliament, so the trust cannot opt out of this. And so we're in this difficult situation where we're potentially 3 weeks away from being in a circumstance where we're already in a position where we can't open all the beds we'd like to at the minute because of staffing concerns. That may become worse as a result of the mandatory vaccination if we're not able to see some real shifts in those numbers. I think it's very important that we recognise and respect the concerns of some members of staff who've not had their vaccination. And I think in looking at social media and looking at some of the coverage of this, there's been quite a entrenched set of positions taken around this, and yet talking to a number of our staff who've got concerns, people have all kinds of different reasons for having concerns about this. And I think the risk is the more that we draw these as very entrenched lines, the harder it is, I think, for people who've not so far had the vaccination perhaps to change their mind and decide to come forward and have one. And I think we need to be careful not to present it as almost an unethical thing to do to not have the vaccination, because I think what that risks doing is driving people into quite hard positions about this. And I would like us to create space and time to have appropriate supportive conversations with colleagues to encourage them to change their mind. I will be extremely sorry if we have to let experienced members of NHS staff go because they haven't had their vaccination, and yet as a contractual condition that will be the effect of it in 3 or 4 weeks' time. We are looking at the services that will be most acutely affected if we don't see significant improvements in the numbers, to understand what the operational implications will be. And we're also working through managers, through peer conversations. The RCN have run a very, very good seminar for our staff to tell them about the vaccination and to explain the information there. We're doing weekly question time with the execs, and this Thursday we'll have a couple of colleagues to share more information about the vaccination and so on as well. So I'm really hopeful that we can get that 1,300 number right down as low as possible. But I think at the minute it looks like a material risk that a small number of staff will be in breach of the terms of their contract come the 3rd of February, and that will have consequences in terms of their contract of employment. That was the sort of last thing I wanted to raise in terms of my update. And obviously it's going to be a very fluid picture over the next couple of weeks, but at the moment it's a material risk, and a material risk that we're planning to address as best that we can as a leadership team. So I think that was the main things, Jackie. I suppose just in summary though, it's a big thank you to our staff because they've really pulled out the stops. It's been a pretty exhausting period, I know, for many of them. I know from talking to a number of colleagues as well, I've had quite a few conversations with people where you can feel that their emotions are running at a quite high level. And I've had a couple of people who have ended up in tears just through friendly supportive conversations, asking how they are. And I think there's been people where their emotions are simmering not far below the surface really at the minute. And I think that is a result of quite a prolonged period of working in conditions of high stress, both professionally and personally. And of course, a lot of folk have been off sick as well with COVID in the last couple of weeks as well. So it's been a tough time, but the staff have done magnificently for us. Extremely proud of the way they've gone through it. And now we have these quite tricky conversations about mandatory vaccines to negotiate in the 3 or 4 weeks ahead. So happy to take questions on any or all of that.
Thank you, Matthew. Are there any questions for Matthew on that? Linda, and then Joan.
It's not a question, it's a statement really about the vaccinations. I'm sure Matthew will be aware that all volunteers and patient partners have been sent a similar letter, I'm sure that's been sent to staff, to say that we are also required to have the mandatory vaccinations in the required timescale. So we are also working on getting registered to make sure that we are also safe and making sure that we comply with the same regulations as staff do. Thank you.
Joan.
Yeah, thank you. Matthew, I do think that what you've said there about the staff working tremendously hard, I just want to acknowledge that. Obviously, as a board, I personally want to acknowledge it. I cannot imagine. I have family members who work in healthcare and it is tough. So my huge thanks. Also, obviously, what you said about the approach to vaccinations, I think is absolutely the right one. If we drive people into entrenched positions, that's not going to help anybody. So really thinking about who are those arbiters who can bring the information in the same way that our staff might bring the information, such as the RCN. I think it's a really great idea, and any others that we might think of, how we as non-execs can support some of us in our roles who maybe work in this area of just trying to unearth the actual facts. Please let us know what we can do, but I think you're taking the appropriate action, and thank you to all of the executives just working in really hard times.
Thank you, Joan. Ruth?
Again, I'd say thank you. I just want to say what a good letter it was, actually. I think it was very clear, concise, fair, and I think had a lot of empathy in it, whilst also drawing a line of this is just where we are. The only thing I was going to say from a community point of view is any way that we can help support giving staff vaccines, because I can also see some that may have actually been quite vocal to say I'm not going to have the vaccine, may not want to have it at the hospital sites to be seen to then go and have the vaccine. They might find that quite difficult to do. So if they want to be vaccinated elsewhere, I will happily fast track them through any of our sites so that they're out. And also if they want to speak to, again, people outside of the trust about the vaccine, but not even necessarily their own GP, I can certainly put them in touch with health professionals that know heaps about the vaccine, and we're more than happy to talk to them almost off the record. That would be absolutely fine.
Ruth, that's really helpful. Thank you. Thank you for that. And Catherine has also pointed out that the Royal College of Midwives are doing information sessions as well. And Catherine, you've got your hand up. That might have been what you were going to say.
No, I wasn't going to say that. I just thought I'd put it in there for information. That just so that people know the RCM have got that supported by some imams and the Archbishop, so that the religious concerns that people have can be addressed. But actually, I was going to pick up on Ruth's point, really. It's a conversation that I've been having with a number of staff who are teetering on the brink of wanting to have the vaccination. And I've said I'm very happy to vaccinate and come to my office. I can go to them. We can do it slightly discreetly for exactly the reasons that you've described. If you've been very vocal about it and you really don't want it, how do you backtrack from that? So I really welcome that, and we'll add that into the mix. Thank you very much, Ruth.
Matthew.
Yeah, and I mean the other thing to emphasise is that there's a group of our staff who are concerned about it. And I'm going to meet a group of them on Thursday just to talk through some of this as well. I think what we need to be very conscious of is the way that social media pushes people towards extreme positions. We've seen this a number of times in recent years, but once someone starts to look down this, we get into more and more difficult positions in terms of this ability to offer a bit of flexibility around it. So I think that whole point about us getting this messaging right, I would like everyone in the trust to be vaccinated. I would like everyone in the trust to do it because it's their choice to do so, and because they recognise the really high degree of protection it's been given. And I think for the staff who can see the people who do turn up in critical care in their 30s, 40s and 50s, the pregnant women in critical care they've had to go, you know, if you're unlucky enough to get severely unwell with COVID, the vaccinations do clearly offer a measure of protection there. But, you know, this is a very difficult ethical issue, and I think it's just really important that we reflect that complexity and we treat people with a degree of compassion as we work our way through the next couple of weeks. It is quite quickly they're going to switch from this to being quite a difficult operational context if we don't see those numbers shift, you know. So even 50% of what we've currently got, if we were in a position where we're talking about hundreds of staff who are unvaccinated come the February 3rd in an operational context, that is going to become operationally extremely difficult. And we'll make sure we keep the board aware, you know, with all of our energies in the meantime directed towards asking people to make that decision to have the vaccination.
Also, Matthew, I think you mentioned this, but just to be clear, of that 1,300 that you mentioned, it's highly likely, isn't it, that some of them are in fact already vaccinated, but that we haven't got the data. The data hasn't been cleared properly for that yet.
Yeah, I mean, and some of our staff have had other vaccines overseas, and you know, so we're just trying to get some clarity about, for example, if you've had a vaccine in another country and it's not one of the UK regulated ones, does it count? There'll also be plenty of people. If your family and friends are anything like mine, it feels as though 50% of everyone I know has just had COVID over Christmas. There are factors around the timing of recent COVID infections. I believe there's something going on with a tennis player in Australia. I don't follow tennis myself, but you know, where if you've had a recent infection yourself, also you can't have the vaccination for a set period of time. So there are some wriggles. There will be new regulation from NHS England, new guidance rather from NHS England hopefully on Friday or Monday. That may change some of the ground we're on at the minute. So we'll make sure we do keep the board fully updated on what is very much a live position.
Great, thank you very much. And also, you said it, Matthew, and the rest of the board supported it as well. Enormous gratitude to our staff for the way in which they have responded to what everybody hoped wasn't going to be essentially another really big challenge this Christmas, and the fear of a peak, which is a peak in cases, but hopefully not the peak in admissions, particularly for the most serious that we feared that it might be. But obviously that brings back all of the pressure and all of the tension for our staff on top of the work that they're doing so very well, in fact, in terms of the recovery, as we'll talk about in a bit more detail later. So hopefully we can record that and transmit that to the staff as well, our gratitude for all of their efforts. Let's move on then to the board assurance framework, which Linda will introduce, but just to sort of remind the board that this was what we were able to look at and talk about in the seminar. And as the report says, we made some changes to what was included within the board assurance framework to following that conversation. And of course, it's very important for us as a board because it identifies those areas of highest risk and the action that's being taken, which of course should be the things that we as a board are focusing most of our attention on. So it should drive our programme and our thinking. Linda.
Thank you, Chair. I'd like. Is this repeating? Sorry, I've got a lot of echo. Can you hear me okay? Oh, thank you. Okay, I'd like to just sort of highlight three key areas from the report. So that's the improvements made to the framework, the current position and the next steps. So as Jackie mentioned, the board seminar reviewed the framework in December last year. And the improvements made to that framework were basically to have a clearer focus on the Trust's organisational objectives and the risks to those objectives. We wanted to make a really clear link to the Trust's risk registers for high scoring risks. So we now include a larger section on that for those risks that score above 15 on the Trust risk registers. Where we don't have anything on the appendix there for those red risks, that's because there aren't any on the risk register. So hopefully that area is now much clearer. We've also included space for risk appetite information, and the plan is to have a seminar session in February on the risk appetite with the board, so that we can progress that and then incorporate that part of the risk work into the framework. In addition, there's a new section in the appendix, which is a narrative section to set out the current position of the risk. And the aim of that is really to draw together in a narrative form what all of the information and status on those controls is actually showing us. I've also repositioned the information with an aim to make it easier to read as a risk on a page, with the history of the risk all down one side on the left, and the controls and assurances and actions being undertaken on the right hand side. So quite a lot of work to rejig the framework, but hopefully that does make it more usable and clear for people to read. The second area that I'd like to highlight is actually the current position, where we've got to as a result of the discussions in December. So at that meeting we agreed to remove some risks, and that's set out in the report. And what we've been left with are 14 areas of risk. Of those 14 areas, 6 are red rated, and those areas are COVID vaccination of staff, as we've recently been discussing, urgent and emergency care performance, restoring cancer services, financial sustainability, digital and care equality. The remainder of the risks are all amber scored, and I've tried to put a summary in the narrative report in section 3 on that. The next steps will be to continuously review and follow a continuous cycle of review for the BAF, with the January board committees reviewing their relevant risks, further input from that into the BAF, and then a summary report coming through to the March board. We'll do the risk appetite work and finalise that. And as we develop the objectives for 2022-23, review the framework again. And then finally, we'll be bringing a high-level risk report and the BAF to the next Trust Executive Committee, in order that the divisional directors can see that work alongside and comment on the risks that are coming out of their divisions. So I'd ask the board to note the work that's been taken and the next steps. I'm happy to answer any questions on the development of the framework and the governance around this, and the individual risk owners are at the meeting, who can hopefully answer anything about the content of their individual risks. Thank you.
Thank you, Linda. Are there any questions on that? No? Okay, good. Oh, sorry, Mahbub.
Sorry, I wasn't quick enough to get my hand up. Thank you very much, Linda, for the work on this. Really good, really helpful. And it's for someone who sits on one committee, it's really helpful to have this oversight across the other assurance committees that we're not members of, and I welcome the opportunity. I guess I've got 2 quick comments. One is on our sort of role as an anchor body on page 25. There's stuff in there about helping local recruitment and development of local skills and talents, but I would have thought that we could have be a bit more ambitious and think about how we use our supply chains and procurement to get social value out of that, and collaborate with others, partners, so we can jointly sort of try to look at things like out the supply chain, getting more apprenticeships, procuring locally for local jobs, stuff like that. On page 23, on dealing with sort of vulnerable patients, we talk about our approach towards learning from deafs and those who have got learning disabilities. But I would have thought that a big part of this would be our patient experience, particularly the experience for those who are the most marginalised in society, and perhaps if those could be picked up as well. And I can see everyone's getting pretty bored, so what I'll do is I've got another one, but I'll pick up that point separately. But just want to finish off by saying that the stuff on partnership in here and the risk controls around that is absolutely brilliant. So well done for colleagues on pulling that together.
Thank you, Mahbub. Nothing boring there at all. Important stuff. Does anybody want to? I'm not sure how much we need to respond to that at the moment, but if anybody wants to, but I think there is a broader point actually that it would be worth our while thinking about in terms of possibly even a seminar topic or something certainly that we would then want to bring back to board around our anchor institution role in the broadest possible sense. You know, it's included in, I mean, interestingly, it's included in various places in the meeting today, whether or not that's in the green plan or something in the second, the stakeholder report in the private part of the agenda in terms of partnership. But I think that's something perhaps that it would be helpful for us to do some more, at the very least, reporting, if not work on as well. Okay, good. Thank you very much, Linda. As others have said, I think that is a really good piece of work and a good basis now on which to be able to use that to guide the board's discussion and assurance. Moving on to quality and safety sections of the agenda. We're starting with the report from the Quality Assurance Committee. Jackie.
Yeah, thank you. So we've had 2 quality meetings since our last public board, and one in November and one in December. I just really want to highlight, I think, 3 particular things in the interest of time. I think the first one is something that's been going on for a bit of a while, actually, which is that we've moved the data presentation to SPC charts, and I think we're still struggling with that. Actually, I think we've still got some concerns about the quality of the data that the committee is being presented with. We've been talking about it for some time, which is why we've decided to escalate it to board. I offered to meet with the data analytics people and Lorraine Bess, and hopefully a meeting is being organised to that effect. But I think it is just something that we need to alert the board that actually it's quite difficult for us to really get a sense of some of the issues, because the data is, you know, there are some issues with the data. That's the first one. The second actually relates to staffing in 2 particular areas. And obviously, Matthew, this would link back to the comments you were just making about staff being vaccinated. Because I think you mentioned women and children as one of the areas where, you know, we had a relatively high number of people not vaccinated. So, and also back to the risk register. So on one of the risk registers, we've actually got a high level risk rated at 25 in relation to maternity services, and particularly essentially around capacity, dealing with babies of women who have very complex pregnancies. A lot of work has been done by the teams, a lot of work working with partners and communicating with partners, asking for help, etc. But I think, and also using really, I think, quite creative ways about how we use midwives and how we use other staff. But I think we just wanted to alert the board that I think our midwifery staff is an area of particular pressure in terms of capacity and maybe worse, I guess, but Catherine can comment on that. And actually, similarly, essentially, there's a similar issue in critical care, where we were actually working very hard, I think, to keep the numbers, the nurse ratios in line with guidance, but it was requiring an awful lot of mitigation, a lot of work, with lots of sort of daily escalations and things. So again, discussed North East London. I don't think either of those 2 issues are unique. Well, I know they're not unique to us, but I think those were the 2 areas that we wanted to highlight to the board. And I didn't really have anything else actually to say, because most of the other papers will be coming on to in the next section.
You're on mute, Jackie.
Jackie, you're muted.
Good. I thought I had unmuted myself, and then somebody, and I will find out who it was, muted me. Thank you, Jackie, for that. Now, this issue about the data that you've identified, and in particular, I think that you've suggested that there needs to be a date by which the work is completed. Have we made any progress on that? Who's the best person to respond on that? Catherine.
I think.
Yes, that's fine. So I think there is a problem with the data in terms of the date the data is drawn down. We think it was a particular issue over the Christmas period. I absolutely agree with Jackie. We've been trying to get this data clean for probably a good 18 months or so. I've got more confidence that it's going to be better now, and we've tried to align the dates of the meetings so that the data can be pulled down and inputted more effectively. So that work's been going on since the last meeting when it was, meeting before last, when it was raised. So I know that Jackie's meeting with Lorraine, and hopefully she'll be able to provide more assurance around that. But it's primarily that is the issue in terms of when we draw the data down and when the closure for the data closure data for the organisation.
Just if I could just add, I think some of the issues as well are that there's the data as in the graph, and then there's the text that doesn't actually always align. And so I'm just not convinced sometimes the person that's actually writing the text completely understands the data, the numbers. And that is a bit of a concern, because obviously we're relying on these SPC charts to go, don't need to look at that, don't need to look at that, oh, I need to look at that one. Whereas actually, if you're not confident, then actually you need to look at everything, which kind of defeats the object. So that's sort of the conversation that Lorraine and I will have. And I just don't understand the quality control process that happens, that I kind of feel it shouldn't get to the Quality Assurance Committee with inaccuracies in there, because actually it's probably gone through a number of other levels before it gets to us. So that just worries me, which is why I think the conversation, we need to have, but we do need to establish a date, because as Catherine said, we've been talking about it for some time now, actually. So I think probably the best thing is if I meet with Lorraine, kind of, if I get a better understanding of just why is this so difficult, and then I think we do need to agree a date between us that we can commit to.
Thank you for pursuing that, Jackie. Sue.
Thank you, Chair. I raised my hand in relation to the SPC charts and data. We received the performance reports under SPC charts at FIPC, and we've been grappling also with how the narratives align with the data and actually how the SPC charts are working for us as an organisation. So I was going to suggest that those of us who are data minded and nerdy about these sort of things, maybe we broaden out a session with the people producing the data, and not just the quality data, but include the performance data, so that we can learn together. So it was really just an ask to look at it in a broader sense, so that we can get really meaningful data that we can all understand and use to target our efforts. Thank you.
Okay, thank you, Sue. Joan?
Yeah, we weren't aware of that. So as a member of the quality committee, would it be helpful to the execs, because staff are working flat out, we know this is a problem. We've had a problem over the year of looking at these charts. It's not a new initiative, and it doesn't ensure that we can give proper assurance by looking at the data that we're currently looking at. So would it help if there is more emphasis on other people, a deep dive with, a consultancy or somebody who can help support staff? Because it strikes me like it's the wrong time to be trying to ask staff to do more, but actually we're not getting any further. I just don't know what the execs might think about that, if that's possible.
Jackie, do you mind if I just come in? And I've just seen that Nick has said I'll convene a data improvement. I can't remember when it was it a couple of years ago, Nick? We actually had some people from NHSEI who were the experts around this, and they came and gave us a kind of training course. And back to picking up your, Joan, rather than paying consultancy, it might actually, but the people from NHSEI might be able to help us with some better insight, because now we know what we don't know. That might be a bit more helpful.
I think the next stage, as you say, Jackie, is as Nick has offered to bring together a group on this. And Joan, whilst you're right that people are under pressure, this is obviously an area which actually supports people in handling pressure. And I think I wouldn't be the only person saying that I'd rather not we brought in more consultants at this particular point. But let's see how Nick bringing together that group goes. And see if we can make some progress, including on bringing together both the quality and safety and the performance data in the way in which Sue has suggested. Good. Let's move on then to the the report itself, to the Integrated Quality and Safety report. And Catherine, I think you're going to bring out anything that you need us to particularly note in this.
Yeah, thank you very much indeed. So it's obviously been discussed in great detail at the Quality Assurance Committee. There are a couple of things that I think are really important that we need to note at this particular meeting. We've obviously been dealing with COVID over the last 2 years, really. We've had a variety of incidents related to COVID, patients, nosocomial, etc. And we're now, over the last few months, been taking a great deal of time looking at the learning from all of those cases. So all of the nosocomial deaths are going through processes where we're really trying to learn and see what we can do differently in the future. So I just wanted to make sure that the board were aware that we are doing that work, and it's quite a large piece of work. It's not a small piece of work for us. Jackie's just mentioned the staffing levels, and there are 2 areas, as she said, that are of particular concern. Maternity, we have about 35 vacancies in maternity. We have a number of people who are joining us either from the UK or overseas, but that will still leave us with about a 10% vacancy rate, which is normally quite manageable. But if the midwives who haven't currently had their vaccines don't have their vaccinations, obviously that will tip us well over the 10%, and that will become an increasing concern for us, which is why we're doing the work that Matthew's talked about, which is really looking at how we're going to manage maternity services. This isn't something that's just affecting us, this is affecting certainly the whole of NEL, and I think more broadly across the England, really. The other area where we've also struggled slightly with critical staffing levels is critical care. If we had our normal bed base for critical care, we would absolutely have the right number of nurses to provide the care at the GPIC standards every day without exception. And that's because we've done a lot of recruitment over the last year. However, we have a significant increase in our number of ITU beds that are open at the moment, which is why the staffing is more challenged. So I think that that's slightly different to the maternity situation. And so hopefully, once we come through this wave of COVID and we go back to our normal bed base, and obviously we'll have our new unit up on the 4th floor, that will no longer be a significant problem for us. And then the final bit that I just wanted to bring to people's attention is about the mandatory training, but I thought that Magda might like to talk specifically about mandatory training, so I'd just like to bring her in.
Yeah, thanks very much, Catherine. I think the board will be aware that we have standards for mandatory training and core mandatory training compliance across all groups of staff. And we have historically been quite challenged to get our medical staff into the required level of mandatory training. And towards the end of last year, we started to put some new processes in place through our divisional teams. And I'm pleased to say the December report reports that we'd achieved 89.13%, but as of this week, we are now at 92.25% of our staff, our medical and medical staff achieving their core compliance with mandatory training, which is a significant improvement on a very difficult and historical problem. It's been done down to the implementation of new processes and supporting our divisional teams to be able to follow those through. Other staff tend to be over the 90% on a consistent basis, but we're tracking this now on a weekly basis.
And that was all I particularly wanted to pull out, but obviously happy to take any questions.
Thank you, Catherine, and thank you, Magda, for making obvious progress on that element of the mandatory training with our medical staff. Are there any other questions or comments on this? Okay, Joan.
Yeah, just a comment, and good to see a lot of the work here continuing on mortality, Magda, and we certainly identified, didn't we, around people with learning disabilities, that we'd have a focus on that. The report also talks about higher mortality in terms of BAME communities, and I thought actually, oh, that's all like COVID, but it doesn't seem to be. Can we just clarify that? So on the front page, it talks about 86 deaths out of 100 or so are COVID related. So can we just clarify what that's about? I couldn't find it in the report as such.
I think that's jumped us onto the Learning from Deaths report, hasn't it? So Magda, do you want to say anything else about that you want to say about that at the moment as well?
Not particularly. I think, Joan, what we're, as you know, we're bringing back a more detailed review of our hospital-acquired deaths with COVID, and we're trying to look at that in the context of backgrounds of our communities and where patients have come from. And we've we'll try and broaden that across into all of the deaths. But I think that's a piece of detailed work that we're undertaking at the moment, and I'm hoping that we'll be able to report back to QAC on this. So that, yep.
Okay. Anything else on the quality and safety report? Okay, so the next thing would have been the learning from deaths report.
Yeah, no, just a couple of comments around it. So this is our Q2 report really for 21-22, and I think I just wanted to pull out a couple of things. In addition to the comments we've already made about the learning from deaths mortality reviews and the hospital acquired COVID death mortality reviews, which is due to come to the Quality Assurance Committee, just to point out that we look at examples, specific examples of where we define patients as having received either poor or on a scale of 1 to 5, poor to excellent care. And I think it's just worth noting that actually the themes for both poor and excellent care are either the lack of or the presence of the same factors, which is around timely senior input, clear decision making, clear escalation plans, recognition of dying patients to allow appropriate palliative care support and communication with families. And it's the same themes from both ends. So it's quite an interesting piece of work that we're going to be doing around communicating that. And then just to note, for the committee to note, for the board to note, sorry, that the SHMI and HSMR have improved. That doesn't include COVID, that the COVID mortality is not part of SHMI and HSMR reporting. And also over the last year, the child death review process has been changed, and we have been updating our internal processes to make sure that not only does the wider review involving other agencies get incorporated, but that we also have appropriate medical and nursing reviews of care as well.
Thank you, Magda. And I should have said in the when I was updating on the collaboration that, of course, when we're talking about sharing staff, you deserve congratulations, Magda, for your appointment as the Group Deputy Medical Officer at Barts. And I'm the person around the table who gets to carry on working with you, but I know, because I've already seen the messages, that people at BHRUT will be very sorry to lose you. But congratulations, and it's very good news, I think, across both trusts, actually, that that's happened. So well done.
Thank you very much.
Good. IPC report, Catherine.
Thank you very much indeed. We've talked a lot in previous reports about COVID, but I think it's important to mention that we're continuing, obviously, with all of the IPC related to COVID, but also that C. diff, which we haven't struggled with very much for quite a long time, is becoming a bit of a problem for us. So the microbiologist is taking an increased interest and really doing additional walk-arounds, ward rounds with the teams to make sure that our antibiotic prescribing returns to pre-COVID levels. We know through COVID, lots of people prescribed far more antibiotics as we were trying to discover how to treat this disease. So that work is ongoing. We have a number of policies that are out of date because, as you can imagine, the IPC team has been focused very much on working with the teams on the front line. So we've actually brought in some additional resource to make sure those policies can be refreshed and up to date by the end of January, because they are, of course, equally as important. And then flu is a significant issue, or potentially a significant issue for us. So we've put in point of care testing in ED so we can test people as soon as they come in through the organisation. And we continue to focus on making sure that people adhere to the IPC standards with a level of rigour that we perhaps didn't have in place prior to COVID, because of the reasons that we all know that we've had to live through during the last 2 years. Thank you.
Thank you, Catherine. On the flu point, I mean, I think last year, aren't I right in saying that generally we saw much less flu, probably because of the care that everybody was taking. Are we seeing more normal levels this year, or are we still seeing them lower? Oh, that's encouraging shake of the head from Magda there.
It's still lower, Jackie, and this is a national picture. It's probably partly to do with all of the precautions that people are taking, as much as vaccinations as well, but we're not seeing the same levels of flu.
Good. Wash your hands and don't hug so many people. Maboob.
Thank you. I'll do exactly that, Jackie.
Present company accepted, obviously.
Yeah, of course. On the microbiologist approach and reducing the prescribing of antibiotics and stuff, can I ask Catherine, do we have a sort of a approach whereby we've got lots of data about individual people who have got the sort of license to prescribe, and we can track those who might be over the medium and be able to have a more targeted approach? Or is it sort of a general education and awareness program?
Yes, it is the latter. We don't have individual data, but what we do know is that we have moved back to over-prescribing, which is why the microbiologist is doing ward rounds with the teams to re-educate people. Pharmacists are being encouraged to go back to really checking the charts and making sure that if you're at 3 days, they're asking if they need to continue, etc. So we're going back to the level of the rigour that we had prior to COVID. It's just a bit of, I mean, there are a few things where we're having to really reinforce things that were embedded in normal practice prior to COVID, and this is one of them. Really.
A quick supplementary for me, would digital prescribing help us, and do we know if we're on the path trajectory for that to happen?
The digital prescribing absolutely would help, and our Nick might want to comment on the EPMA programme, which I think is not quite as rapid as we had all hoped, but I'll leave it to Nick to comment on that.
My experience of a trust with very sophisticated digital prescribing technology was that it made a massive difference. It was one of the most significant things. Ruth.
So I was going to expand on that. So obviously, all electronic prescribing, and the audit data you can get from it is fantastic, and you can certainly find out who's being naughty and who's being very good, but also patterns of behaviour. But Catherine's really right. It's really historical behaviours and clinicians really believing that 7 days is better than 5 because this is what they've always done and that's their experience. And it's quite hard to reverse that, I think, over time, but it's just constantly having to do it. And for really importantly, empowering the pharmacists, who I think also can be seen as lesser clinicians, and actually they are incredible at what they do, and we just need to listen to them more.
Nick.
Yeah, thank you. Magda and our Chief Pharmacist, Sala, led a very powerful and persuasive discussion this morning, actually, on the benefits of EPMA. So we would hope to bring that to the board, probably for the March board meeting.
Okay, good, thank you. Let's move on to the nursing and midwifery 6-month staffing review, Catherine.
Thank you very much indeed. This is the October 6-month staffing review. At the last board, we had a staffing review as well, but we're now back on target, so we won't have another one for 6 months. So the data in here talks to whether we are staffed appropriately, and due to the work that we've been doing through the Workforce Hub, supported by the finance team and FIC, we have now got most of our wards with the appropriate staffing based on the acuity and dependency of our patients, so that's really good. We have a couple of wards which have been set up as interim wards, so SDEC and the Children and Young People's Assessment Unit. If we're going to keep those on a permanent basis, we need to recruit now to those on a permanent basis, but all that work is in the pipeline. The Workforce Hub, who has been leading on this work, particularly over the last 2 years for us, and I think we've been able to demonstrate, has really started to utilise the workforce in a much more intelligent way, so based on real data, not on people's thinking or want. It's now going to be funded on a permanent basis, and we're going through that process. And one of my deputies, who did lead on all the workforce work, went to be the improvement director for ED, but I have now been able to recruit to that post, and that person will be joining us in March. And they also actually have come from BART, so Magda might be going over there, but we've got somebody coming back to us, so that was very nice. But I would like to thank all of the board actually and the subcommittees for support in getting this staffing model to the right place with the right sort of commitment in terms of funding, so that we are in a much better place than we were a few years ago in terms of the nursing and midwifery numbers. Thank you.
Thank you, Catherine. I don't see any questions or comments on that. So
Thank you, Jackie. Catherine, I just wanted to say how fantastic it is to see the robustness and the triangulation approach that you're employing. And it's great to see how this is tying into the establishment control work that Alan is leading and the budgeting work that Mike and Nick and others are leading. Just really to say, we are obviously placing some reliance in one of those points of triangulation on the safe care system. And I think we have talked, myself and Mike, about including that in the forward plan for audit for our internal auditors, because I think that would give us even greater assurance about the robustness of our approach. So it's really just to share that with the board, but really great work, really great. Thank you.
Thank you. I think that would be really good actually, because although lots of organisations use the SNCT data, they don't use it with anything like the same level of rigour that we do. So we are really trailblazing in terms of this work. And one of the Chief Nursing Officer of England's team is coming to look at how we've used it, I think in February or March, because other people are not using it in the way that we are, in able to inform how we're delivering care. So I think that that would be really welcome. Thank you.
That's good. Joan.
Yeah, this relates back to, I think, something Matthew talked about, which was the vaccination rates, and one of the professions most hit who might leave would be midwives, I think that's, or within the maternity department. So I'm just thinking about how we future-proof for that, for the next report, Catherine, and any ideas you've got around that, because that could be quite significant or not. And I know we have done a lot of work to look at getting the staffing up to where it needs to be now. So thank you.
Yeah, that's right. So I think there's probably two parts to that. The one part I think about how we would make sure that we future-proof it, Alan could probably answer, because I think that's about people's future contract. But the work that we're doing around the BHR Academy in terms of growing our own, developing our own staff is really important. The area that we've had significant success with adult nurses, as it were, is we've brought people through the nursing associate programme into registered nurse posts. There wasn't the equivalent for maternity, there is now, and we've now got people, they started on that course. I can't remember whether it was September, but recently, I mean, they're 2 years before they'll get to us, but we've started on that same programme of recruitment. It's local recruitment, it's people who've worked as maternity care support workers with us, and they're going to be our midwives of the future. So that pipeline will be reflecting the pipeline that we have for adult nurses.
Alan.
Yeah, just to say, John, it's a contractual requirement now, so that's going to be put in all our adverts, job descriptions, and contracts, that you will have to have the COVID vaccination to work here.
I'm just wondering about if a whole set leave in April, what happens? That's really what I'm getting at.
Well, yes. Any ideas, let us know.
Matthew?
Yeah, I mean, just to assure Joan, so to caveat this with, we're going to do absolutely everything we possibly can to get as many midwives vaccinated as we can. It is a service where the existing vacancy rate plus the unvaccinated rate would put us in really quite serious position. I mean, at the minute, for example, the Queen's Birthing Centre, I don't think it's been open since I got here. And I couldn't see any circumstances in which it would reopen if we lost, another chunk of midwives for the foreseeable future, certainly in terms of the vaccination. If any of the exec team disagree with me on that, please do speak up. But I think it would leave us in a position where we'd have to look at constraining services and focusing in on core establishment being focused on the labour ward. Looking at complex births and making sure we're doing everything we possibly can to manage those as safely as possible, and also looking at North East London as a network of maternity services to think about capacity, because there are very clearly defined ratios of midwives to women, and there's with the Ockenden report, etc., we're very focused on safety and quality in maternity. So that's why we've got to really focus on our efforts on getting, and the numbers as they currently are would pose as quite a significant operational problem for women whose births are booked in from April, which is why we're having such an effort to try to turn that around. I don't know, Catherine, if there's anything else you wanted to add, but there's no easy answer to this other than start training some more midwives 5 years ago, and it's a bit late for that.
So I suppose the other bit is that we are actively looking at scenario planning, what would happen if we were in this position or in the position that we're in now, if 50% of those people decide to be vaccinated, if 70% of people. So we're looking at all that at the moment in tandem with the work around asking people if they want to be vaccinated and supporting people through that if they want to do that. So we're not just sort of sitting here with our fingers crossed hoping it's going to be okay.
Yeah, thanks for the assurance, because that's really, thank you.
Okay, thank you for that. Let's move on to the people and culture section of the agenda, and we're starting with the report from the People and Culture Committee. And in Leslie's absence, Mahboob, I think, is going to present this.
Yep, thanks, Jackie. That's right. But bear with me on this sort of not very good presentation of Leslie's brilliant report. So the good thing to begin with is that as of 20th of December, the committee received an update that 80% of non-medical staff have had their appraisals. And as you're all aware, we agreed a new approach towards appraisal, turning them into a conversation as opposed to a sit-down bureaucratic form, but a conversation about the future development and aspirations of staff, as well as having the tools and the kit to do the day job. One slight amendment to a word that's been incorrectly inserted at 2.4, the second bullet. It should read equality and not inequality. And when we considered EDI in terms of staff recruitment, we found that the greatest correlation between having a positive outcome in terms of equality was the diversity of recruitment panels as a clear collaboration between, clear correlation between the two. And we're encouraging to hear from execs the approaches being made to ensure diversity continues to be a matter of importance for them, and greater focus will be put on that as part of when recruitment panels are convened. The other thing I just want to mention is on the guiding of safe working. We received the reports for quarters 1 and 2. 3 things that jump out from what junior doctors were telling us around annual leave, access to good IT and job planning. These have been taken on board by Magda and colleagues and being addressed, and actions will be brought forward to as updates at the next meeting. We spent a lot of time this meeting already discussing mandatory vaccinations of staffing, but that was a point that we wanted to escalate, but I feel that's been covered in sufficient detail. The other point that we would like to escalate is staff sickness as a consequence of Omicron, and Alan is ready to provide us with an update on that. And my final point is looking ahead, working with colleagues, particularly having conversations with Ben at the moment on reviewing BAF risks when we receive the staff survey, and with a particular focus on staff well-being. We know that issues around vaccination and also staff sickness is having an impact on staff well-being, as well as the ongoing endemic, and that'll be important as to what the national survey tells us, and our ranking, and also our benchmarking with similar trusts. So if through you, Chair, Jackie, if Alan can just give us an update on staff sickness, that'd be really helpful, and happy to take any questions or comments.
Thank you. Alan.
Yeah, so I think Matthew touched on it. We did see obviously a rise in sickness absence, I think peaking around about 7%. I think the statistic that I used it in early December, we had 5 members of staff diagnosed with COVID. That increased to, I think, peaked at about 169. And then obviously we had staff who were self-isolating as well. I think the trick for us was to make sure that we reacted quickly to the guidance that came through, because that was changing with respect to when you needed it, LFTs versus PCR testing, etc. So we were keeping quite a close eye and monitoring it with respect to the staff absence, and we dedicated resources to ensure that everyone who was diagnosed or was isolating, that they received a call from the employee relations team, just to make sure that they were aware of what the expectations were around testing, etc. So we're hoping that had some impact. We knew at the time that we weren't going to get temporary staff to come and solve the problem, so it was we were very keen that we wanted to support as much possible, that people knew exactly when they should be coming back, when they're safe to do so. So that was the work that we put in train. So I think on the whole we managed it reasonably well as could be, and as Matthew said, it could have been a lot worse in comparison to where we were. So I do think it's trickling down a bit. However, the schools went back this week, so it may be in another 2 weeks' time we'll see a spike again. But certainly I think the Christmas and pre-Christmas break, we've peaked there, and it is coming down a little bit, but we're always keeping an eye on things.
Thank you, Alan. Also probably worth just two things that come to mind. First of all, from your report, the committee's report, Mahbub, I've done a couple of 2 or 3 interviews recently across both trusts, in which we've had diversity advisors, internal diversity advisors, as part of the panel. They've been enormously helpful, and they've made a really important contribution. So making sure that we are in a position to supply those to appropriate panels, I think, is really important, and that's a good point from the report. And secondly, Alan, I just cannot let a meeting go by without reminding anybody who hasn't seen your Christmas message. We all thought, I have to say, the exec team and me all thought we'd done a really good job, and we were looking forward to having our Christmas messages broadcast across the trust, and then you come and blew everybody out of the water with your Love Actually tribute. It was excellent. So anybody who hasn't seen it yet, take a look. Caroline.
I thought it was more Bob Dylan, but there you go. I just wanted to mention a bit more about recruitment, because I'm on the People and Culture Committee with Mahbub. The diversity of the panel is really important, and recruitment's such a key part of it. Sometimes having so many people on a panel can be difficult. It can be quite daunting. The last one I did was 9 people. So that's something that there are conversations happening separately, looking at how that is refined, how you still get the diversity of thought around the table, but perhaps with not such a huge amount of people.
Remy.
And Happy New Year to everyone. Just to reiterate what has been said both by Jackie and also by Caroline about that diversity, not just the panel itself, but also having that extra person, our diversity partners present with enough power to actually be equal to the votes of the rest of the members of the panel. And what we've done within the EDI team is ensure that we've trained enough people, and we're looking at the numbers, how many interviews we do per month, per year, to ensure that we have enough people trained to actually sit on all the panels. And as you all may or may not know, we're also looking at our compliance with what we're doing with recruitment. We want to be learning from what's going on a monthly basis, and actually putting that challenge in and that accountability to the recruiting managers to ensure that they're adhering to the changes that we've put in the recruitment policy.
Thank you. And it's lovely to see you, Remy. Lovely though Walsall is, I'm not sure you saw the best of it.
It was not lovely, thank you.
George.
Thanks, Jackie. Yeah, I'm going to wrap it in recruitment and the vaccination issue, because clearly we're going to have to recruit additional people. We don't know what that number will be, and I'm throwing out a suggestion in terms of other things that we can do now, and anticipating that we're going to be recruiting, albeit we don't know the absolute numbers. And then secondly, aligned to that, is there any way that we could advance book staff for April and get ahead of other trusts and both agency? Because clearly, if every trust is in a similar position, there's going to be a very significant shortage of agency and bank availability as well. So whether there's anything we can do to get ahead of the curve, both with recruitment and by tapping into some agency resources that we can use maybe from March, April time.
Alan.
Yes, good point, George. I suppose the the worrying thing about the temporary staffing aspect is the market rate. It's going to be quite scary, isn't it?
Yeah.
And that's one of the potential risks that we may have to factor in as well, that there'll be a buyer's market. So it's a good point that we'll start having the conversations, I think, across with Barts as well around that. But it'll be quite challenging and quite scary. I think with recruitment, we are ratcheting it up. So again, we're talking to Women's and Children's about seeing what we can do around more recruitment there. And again, it has to be with areas where it's hard to recruit, isn't it? So geriatrics, radiology, Women's and Children's are our most challenging areas, and that's across the NEL. But nonetheless, we're talking at NEL level about what we can do on that to see if there's anything. But it will be challenging. But we've also been working with Ben on about how and what we can do to make sure that we do our recruitment as fast as we possibly can, as well as being as safe as possibly can as well. So we're looking at all those things over the next couple of days, next couple of weeks.
Thanks.
Okay, thank you. Which brings us to the Revalidation and Appraisal annual board report. Magda?
So Jackie, I'm going to take the paper as read. It was presented and discussed at People and Culture Committee. If there's any specific questions, I'm happy to. I've got no concerns about the report. It's mandated. Yeah.
In fact, I think it demonstrates that we do pretty well, doesn't it?
We do really, really well. And in fact, it's dipped a little bit this year, but that was to be expected as a result of the suspension. I've got no concerns that we'll be back to doing really, really well from next year.
Great. Good. Thank you. I don't see any questions, so let's move on to the finance part of the agenda. And we'll start with the report from the Finance, Investment and Performance Committee. George?
Thanks, Jackie. We had two meetings, one on the 24th of November, one the 22nd of December. And apart from the internal audit reports in December, we've got 7 of the items coming to board later for discussion. And I will maybe elaborate more on the King George's Theatre outline business case at that point, Jackie.
Okay, thank you. So let's move on then to the integrated performance report. And Richard, I think you're presenting this for us today.
Yeah, thanks, Jackie. Afternoon, everyone. So again, take the report as read, just try and pull out a few points if I may. So starting with the 4-hour performance. So clearly the focus is on working with the winter director, and we also got enhanced site teams at the moment focusing on flow at both sites. I think it probably means that we came into we've been able to recover our flow position at both sites quicker than we did last year, albeit under slightly different circumstances. So alongside the recruitment of staff and the opening of beds that Matthew's alluded to in his earlier report, we're continuing to work on our front door processes and streaming. So that means the work with PELC and looking to align and ensure consistency across North East London on that side, and continuing to review our ambulance receiving centre that's now co-located in ED. We're doing a particular focus of work at the moment, particularly this week, on internal and external processes to maximise hospital discharges. So we're running a flow week this week to really try and push that. I think sort of turning to elective, as part of our winter plan, I think we're very focused on the fact that maintaining elective is really important for us as far as non-elective is concerned. So we know that a significant proportion of our surgery patients that come non-electively are actually on our waiting list. So stopping elective or slowing down elective does have implications on non-elective. So we're really keen to maintain as much elective as possible. And we've really been able to do that this January to a much greater extent than we did last time around. So just a little bit on the numbers from a 52-week point of view. November, we're about just over 100 ahead of our trajectory. I think it's worth recognising that that rate of improvement has stagnated a little over December and January for obvious reasons, both from a workforce perspective and some of the winter challenges. was to some extent a planned slowdown just to try and manage those expected staffing demands. But I think it's worth the board recognising that that December trajectory is probably going to be quite tight, I would suggest. We were aiming for around about just below 900, so that's going to be quite difficult for us, I think, for December, but we'll continue to maximise as much activity as possible. The measures we're putting in place over and above the Blitz initiatives that we've talked about quite a lot through boards, introducing triage at the front end of our referral pathways to try and support our long waiting patients, and also we've got some access to additional independent sector capacity we'll look at trying to bring to bear there as well. The second point I wanted to make particular reference to is we've introduced a new radiological information system in imaging that's caused us some problems as far as data quality is concerned. So the November report looks a bit odd, but we're hoping that that will be resolved for the January report, and I can see that the waiting list is coming down considerably from an imaging point of view, but that's one to keep an eye on. It's worth pointing out that there's a bit of short-term pain for long-term gain, because this new system gives us the opportunity for order.com, so electronically ordering referrals for imaging rather than relying on paper. So really helpful for us in the long term, but it's causing us some operational challenges at the moment. Just to say on cancer, we are starting to recover our 2-week wait performance after the challenge we had, particularly on the breast pathway, the latter part of September. So we expect to be close to compliance come December. Our 62-day performance still isn't compliant, but I think it's worth pointing out that from a November point of view, we're at 77% against a London average of 69. So we are holding our own, but clearly there's more progress we can make, particularly around the diagnostic side of that pathway. I'm happy to take any questions on any of that.
Thank you, Richard. Could you say a bit more about the flow week? What is it that you're finding is the biggest barriers to moving people through the system, and what are the things that are working to the extent that you know so far?
So I think Matthew's got his hand up. I don't know whether he wants to kick off, and I'm happy to add anything to that. Matthew?
Yeah, I mean, I'm part of the North East London discharge group. Actually, we meet regularly on this, and Richard and the team are really cracking away on flow. I suppose what we had a couple of issues around obviously COVID and infection prevention and control in social care and in community that's really slowed things down recently. You know, the whole regime of making sure that we've got people tested, we understand their COVID status before they move out to care homes, also staffing pressures out there. So there's issues around that. But there's a lot internally we can do about it. And what the team have identified is that we really do have this issue where sometimes you identify someone's ready and it can be 24, 48 hours before they actually go home, because we then sequentially start a series of steps that will allow us to get there. And it's not just complex discharges, you know, the things where you need to get key safes and equipment into people's homes. Sometimes it's some of the simpler discharges. And what we're really doing is looking at some of those internal hospital processes to see where we can make inroads into that. And actually, one of the things about the new ward at King George, for example, Erica there, that's a nurse-led ward, so there's no medical presence on the ward. We can call on medical support if we need it, but those are all patients who've been cleared by the medics and who have a discharge planned for them, and they can then go into Erica ward and be well looked after by our nursing staff while they're waiting for a transfer to an external care environment as well. So what we're really trying to do is be very focused on where we can identify internal delays, and where there are external pressures on the system, what can we do to increase flow within it? So there's a kind of whole hospital model piece for us to do about this. And on a flow week like this, we have senior presence on the floor, and we've called in extra medical support to get decision making improved. You know, we target our staff in at the areas where we think we're going to have the biggest impacts. But, you know, you often find lots of it is about transport, lots of it's about getting medication ready for people to go home with it. And lots of it on the wards is just giving the ward staff the time and space to concentrate on seeing people who are ready for discharge, as well as the new people that have arrived or the people that need you, they're having to look after. So there's all kind of factors to it, Jackie, but a lot of it is very process intense internal stuff really to crack on with. So there's all kinds of elements to it, but we'd be happy to bring a report to the board on some of the learnings from Flow Week in due course.
Great, thank you. Mabu.
Thanks very much. From what I've been picking up regarding flows and discharges into care and residential settings has concerned me around the ability to be able to discharge patients who are medically optimized but are positive for Omicron version of COVID, and how, Matthew, is that being approached? Particularly concerning is the sort of sustainability of a lot of our social care sectors and providers. Their financial sustainability is a major concern, and is that something that we're approaching singularly but also collectively as a system as well? Perhaps when we have a discussion about flow here in the future, we could also think about how we might want to be able to address some of these for the long term, such as, you know, having step down facilities of our own. So we've got a certain number of beds provided, perhaps, you know, off-site in partnership with BHRUT within the community, where we've got the control over that capacity and how it's used, and that perhaps is a potential for partnering arrangements, and particularly with BHRUT being an FT and more freedoms and flexibilities around what it can do.
Yeah.
It's not FT, by the way, Mabu.
Oh, sorry.
Do you want me to come back on a few of those points there, Jackie? Thank you. So Mabu, certainly on the care home side, so can I just put a shout out to Barbara Nichols, actually, who's been working on the social care side with Andrew Blake Harbert and others to really support the health system and social care system to work together to try to make sure we've been able to get people back to their homes, their new admissions to care homes over the winter. It's very much been a system effort. There's no doubt the care home sector is in, you know, it's had years of real challenges in terms of workforce and investment. And I mean, I was at CQC 10, 12 years ago when at that point the alarm bells were ringing about the level of severity that people displayed before they could get publicly funded support for care homes. And I think, you know, the situation's just got worse from them. And what you tend to find with all these things is if you don't have enough support in the community, it all winds up in the acute hospital. The problem is if you keep chucking money into the acute hospital, all you're doing is looking after people who are already sick. And Ben Conway did some really interesting data for me recently, looking at King George and Queen's, and what we can see is that, you know, if you look at, I'm just looking at Queen's at the minute, for example, over 75s account for 30% of our emergency admissions, and yet account for almost 50% of our bed days. You know, and you know, similarly at King George, I think it's about 47% are over 75, and yet it's about 56% of the bed days. The hospitals are disproportionately caring for inpatients who are older and at end of life. Just because though we say people are medically fit doesn't mean they're well to go home and, you know, live a happy, healthy, independent life. Unfortunately, they often do need quite a high level of support as well. And there probably is a place somewhere for you know, good old-fashioned kind of cottage hospital type models where people are still receiving nursing care in a bedded environment with therapies input, but they don't necessarily need acute medical consultants on hand and the full machinery of an acute hospital in place. And I think one of the things I want us to have a really good look at this year, working with NELFT and working with other colleagues, is to understand how much of our bed base is adding value, because there's always a place for inpatient care, but actually how much of our bed base is effectively caring for people who need some kind of round-the-clock care, but it doesn't need to be with the full panoply of acute hospital diagnostics and clinical expertise on hand as well. So, you know, if we come through this pandemic and don't start to think about some really quite significant changes in how we look after particularly our aging population, I think we'll have missed a really big learning opportunity here. Because if you go around I mean, Catherine and Magda and I did a few 4 a.m. visits to the hospitals, both hospitals just before Christmas. And one thing that's really striking, if you walk around the site at 4 or 5 in the morning and you get the chance to look on every ward, is how many very, very old, very frail patients we've got in our bed base. You know, I was talking to the Red to Green team this morning about Flow Week, and they were saying, well, there's a lot of very sick people in the hospital at the minute. This isn't just down to COVID. This is just a lot of very, very unwell people. And they maybe don't need to be here, but they need to be somewhere, and someone needs to be looking after them. So it's a tough picture, Mahbub.
Thank you. Jackie?
Yeah, just really quickly from me, I think actually the team have done an amazing job to keep the elective work going to the rate that we have. I think we know from, you know, many other hospitals that actually, you know, the challenge of COVID or staff being away has been so great that actually that hasn't been possible. So I just really wanted to acknowledge, I know that's a huge amount of work, but clearly it makes a massive difference. So I just think well done, guys, on that.
Thank you. Okay, anything else on this integrated performance report before we move on? Okay, let's move on to the finance report then. Mike, I think you're present to present this. Yeah.
Yeah, thank you, Chair.
Absolutely.
Thank you. Everyone. I'll just pull out some key messages from the report if I can. So this is the report that covers the first 8 months of the year, so to the end of November. We're £2 million better than plan for that 8-month period. But that plan includes all of the COVID and the winter as well as our underlying position. So I just want to go through kind of some of the main building blocks of that position. The underlying deficit remains at about £6 million per month, and we've been targeting getting that down to 5. That was through delivery of halving the banking agency premium and also roughly halving the elective utilisation waste. So it looks like we're going to get to about half of the 10 million per banking agency this year. And we are also delivering elective benefit, but we are also adding cost to do that by adding additional capacity. And ideally, we want to be doing it through improved use of core hours. So there is further opportunity there. So the underperformance in those 2 areas plus some necessary trust funded investments mean that we are remaining at about 6 as opposed to delivering the 5. Now, in addition to the underlying position, we have got the direct cost of COVID, which we're averaging about £2 million a month, and we expect there to be an ongoing funding stream for that for the foreseeable future, and we'll wait to see the planning guidance to understand what that says for the money. The indirect costs of COVID, for which there's roughly 40 million, is split across non-elective capacity, largely through extra beds and extra staff across 7 days, supporting the elective recovery with additional capacity whilst we drive that utilisation improvement. The inefficiencies of IPC, and we've had to increase some corporate costs, the largest areas being things in the estates area, so extra security and cleaning, for example. So they're all the types of costs that we'll have to keep a close eye on as kind of the pandemic unfolds and what comes next. On the capital front, we've got about 41 million available to us. We're forecasting that we will spend all 41 million. There are some challenges around delivery because of the operational environments to deliver in and the IPC and some of the external factors around supply chain. So we'd remain agile and do the best we can to make good use of that 41 million. And as we're on plan, the cash position remains pretty decent. We've got about 47 million in the bank, so we are paying 94% of our suppliers within 30 days. So that's a summary of the position. Jackie, very happy to take questions.
Thank you. Are there any questions? No? Okay. Let's move on then to the green plan. We touched on this at the last board, and clearly it's very easy and right, I think, for us to focus on the very considerable current challenges that we're facing as a trust and that our staff are facing, but to be also able to take a broader approach to our contribution to tackling climate change and our responsibility to be part of the NHS's drive to net zero, I think is also important. And I know, and I was able to meet with Andrew, who's done a lot of work on this before Christmas, that there is a lot of work that's been going into developing this plan and the ideas within it. So it's good for us to have the chance to review it at this board today. I think, Steve, are you presenting this today?
I'll pick it up. Thanks, Chair, to start with.
Okay, thank you, Nick.
Huge credit to Steve and the team, though, for putting it together. So, as you say, in October 2020, the NHS published its net zero plan, and the aim is to get to net zero by 2040. and there's a variety of themes in that paper. We picked those themes up, and our part of that target is to try and reduce our admissions by 2/3 from an 18-19 baseline through to 2030, so over that 11-year period. And the paper sets out where the sorts of areas of focus might be, and hopefully in a way that's very consistent with the Green Plan for BARTs. So what we're next going to do is a couple of things. We're going to get a joint lead across our two organisations for admissions, which will be great. So that recruitment process is happening at the moment. And then you'll see towards the end of the document, there's a whole series of next steps. And really that turns all these opportunities into a firmer plan that will reduce those net emissions. I'd be delighted to take questions.
Thank you, Nick. You're actually, this has been a very good area of work, I know, across BARTS and us at BHRUT. We're actually ahead of BARTS in presenting it to the board, so excellent work. Any questions or comments on the areas contained within the plan? Mahbub.
Just a very quick comment in that this is part of the day job I have in local government, and I think it's really good, Nick and colleagues, in collaboration with BARTS, brilliant work on that, and traditionally an area that the NHS has been slow to catch up on, and I think it's very helpful to have this here set out in the way it is, with the clear, strong ambition behind it at local level to make that difference. So so thank you, and kind of look forward to updates on progress of its implementation.
It's really fascinating, actually, because obviously, as you say, this is an area where there is a lot of work going on across a lot of sectors, and there are some very interesting specific NHS issues like anaesthetic gases, for example, that until you focus down on them, you would never have thought would be as significant as they are in terms of their impact. Joan.
Yeah, I think BHRUT have led on this area for a long time, and so the time has come when everybody else is focusing on sustainability, and I particularly like the piece that talks about how we actually engage with local people as well as our workforce. We know that at least over 98% actually of the public think that efficiency when it comes to sustainability is really quite key. So it's kind of working. I wonder how we intend to work with our local communities, not just in terms of them being alongside us, but also coming and working for us. How do we intend to kind of socialize the areas of this plan where we can have local people endorsing what we're doing and seeing us as a part of the community? An example might be, so we know inhalers and the use of inhalers has been quite a big theme, not only from an efficiency point of view for the trust, but also better ways of controlling and managing healthcare for individuals is something that we know communities as well as our workforce would be involved in. That's just an example, but I wonder how the ways are we engaging with our communities on this great plan, by the way.
Thank you. Jackie.
Yeah, so maybe a little bit linked. So I guess I'm left thinking, wow, this is a lot. And on the one hand, that's fabulous because clearly this is a massive priority and we need to do all we can. I guess my question is about when we're communicating this, do we just need to kind of get a smaller number of bigger priorities that would then help the conversation that you were saying, Joan, about how we engage with people on it? That I wouldn't want us to try and do everything and not do anything, then therefore not do anything. So do we need to go from this to actually, okay, and I know you clearly say what are the next steps, but there's still quite a lot of next steps. So for me, it's just a bit about, of all of those things that are really important, actually, where are we going to start and how do we really make some impact? So it's not at all a criticism, it's just a recognition that there is just a lot here. And I think Sue said it in the notes, the breadth's extraordinary, you know, so it would just be, do we need some focus for really what are we going to do next?
Caroline.
It's kind of related to what Jackie was saying there. I was interested out of all of this, what do you think is going to be the biggest challenge out of all of it? The key thing that's going to be the hardest to crack?
I'll take Linda and then we'll come back to Nick to sort of round off on this. Linda.
Thank you, Chair. I mean, I know that during COVID, there's been a huge amount of online outpatients appointments. And I know, having been working with the access policy arrangements, the review of the access policy, there's lots of ways about the ways to improve the service. However, at the end of the day, the patients, there are lots of patients who would prefer to see people face to face. And I think whatever you do, and you know, I'm committed to the green agenda as anybody else, and the local authority with whom I'm associated have got their own green pathway. So I think, you know, when we start to look at what's going on across the three boroughs, we perhaps need to have a bit more linkage with what each of the local authorities are doing as well, because there may be some additional benefits. But coming back to the patient bit, at the end of the day, the hospital exists to support patients during their, you know, their difficulties in terms of their illnesses and their medical conditions. And I think what we mustn't do is to lose the fact that the patient focus and the patient experience is very important. So whatever we do need to take into account the patient's perspective of this. What we can't do is just rush away and do things because it's convenient for the trust. It's got to be the convenience of the community, which, as Joan has alluded to in part, and the fact that you're there to serve the patients at the end of the day. Whatever else you may do, they've got to be the focus. So whilst I support, you know, the patient element of this, I think we need to be careful how that is sold to the patients, and so they don't go away thinking that they cannot get a face-to-face appointment if that's what they choose. Thank you.
Nick.
Yeah, to answer Caroline's question first, then I'll come to Linda's point. I mean, the source of a lot of the emissions are medicines and medical devices, and then the energy consumption and emissions for acute hospitals. So they're the big areas. I think, to your point, there'll be a number of things which naturally fit with what we would want to do anyway. Patient convenience, for example. So they will be relatively easy. There'll be others that potentially conflict a little more. And I think where it costs more money or there's negative patient impact, they'll be the more difficult areas to balance. But there's an awful lot to go at here, so I'm sure we can find a way through all of that. And completely agree with your point, Linda, about that patient focus. The aim of this, as I've just said, really is to end up with something that's better for patients as well as better for the planet. The last point I should have mentioned, actually, is something Alan mentioned, is if we get this right, this is a big attraction for recruitment as well. There's a lot of people that quite rightly take this issue very seriously, and the fact that we are as well is a positive for recruitment.
So sorry, Nick. Sorry, Chair. I just wanted to ask Nick if you could answer the stuff around, well, how are we going to engage with communities and stuff Jackie was talking about? Where is that in the planning? Do we have an idea of how we'll do that?
To be honest, I don't actually have a detailed understanding how we do that. Let us pick that up.
I'd read my meeting with you, Nick, if that would help.
And I think it links to what Mahbub was saying, and I think Linda as well, that there is a lot of, this is an area where we need to lead, but we also need to work in partnership across, for example, with local government and with others in terms of the initiatives that are happening. And that, along with how we engage with both our patients and our communities, I think is a very important next step on this work. Richard?
Yeah, the only thing I wanted to add in terms of Linda's points, I suppose I should say thank you firstly, Linda, for your active involvement in developing the patient access policy. It's been really helpful to have your voice on that. I think as far as developing that piece of work, clearly we have the policy, but the trick is how do we turn that into reality in terms of how our processes best support interacting with our patients in the way that they want to interact with us. So we have some technology that we hope can support that in terms of patient portals. But clearly, I think our internal processes are probably not flexible enough at the moment to cater for changes in patient need to be seen face to face, to be seen virtually. And we're sort of seeing that at the moment through the current COVID wave, where actually the converse is happening, where patients want to be seen virtually, and we're not flexible enough in terms of our process to be able to do that quickly. So I think that's a big piece of work for us as we move into next year. But just to highlight and thank you, Linda, for your support on all of this.
Good, thank you. Important work, and I think, as others have said, we will obviously want to bring this back to report on progress. Mahbub, did you have something else to add?
Yeah, just one quick comment based on what I've heard from colleagues. Yeah, I mean, I've been involved in leading on this agenda since 1998, and you know, my youthfulness betrays the years. But I can tell you, it works well when you have a large overarching strategy and it becomes business as usual. That is the culture change that we're looking to make, that everyone thinks about climate change and carbon footprint as part of the daily job. So you necessarily don't have to prioritize things in the strategy because it's just happening all the time. And that is our challenge, I guess, and that's something for all of the assurance committees to be thinking about when we receive reports. The section on there, what's the impact on climate change, and how we're changing that through our organisational fit and form.
Thank you, Mahbub. I think that's a really strong and important point. Ben.
Yeah, thank you. Really quickly, I'm just struck by how consistent our goals and most trust goals are for anchoring with the environment. There's a crossover there that I think is really significant in terms of the way that good anchoring focuses on the environment. So there could be a way of thinking about the crossover there in our future strategic work. Just a quick thought. And on desflurane, which is the commonly used anaesthetic, Remy and others will know more about this. There's some trusts that have utilised and can identify a improvement path in relation to carbon that relates to anaesthetics that we could draw out even more explicitly in coming weeks and months. But there are better experts to guide that than me, far better experts like Remy. But I think there are some acute collaboratives that have probably led the way even more quickly on some of that work.
Remy.
I just had to come in here because it's anaesthetics. Two things. Jackie, thank you for highlighting the fact that anaesthetic gases contribute about 5% to our waste, and really important. And what we have discussed as a division is really converting the use of inhalational agents, which are full of carbon, including desflurane, and using what we call total intravenous anesthesia. It's much better for patients in every performance criteria. There is a cost implication to it, but apparently by the time you've used it for a while, it evens out. And if anything, it's probably cheaper. You're not damaging the ozone layer. As regards desflurane, it's the one inhalation agent that has the largest carbon footprint. So we don't have it in the trusts, Ben. We don't use it at all. And I think many anaesthetic departments have stopped using desflurane for that reason.
Mm-hmm.
Thanks, Remy, for putting me right. Thank you.
Yes, we are at least marginally, if not more than that, ahead on that particular area. Excellent, good. Okay, thanks very much. Thanks for the work that's gone into that and for the enthusiasm. Oh, Matthew, on the topic of enthusiasm.
Just one interesting conversation just about the Queen site is, and Nick's well aware of this, is, you know, we're obviously really keen, as we've said in here, to do more things like encouraging more electric vehicles and so on. And, you know, I say this because I have a small part of my brain that's constantly thinking about parking. A very significant part of any NHS trust's strategic planning. But one thing that's worth registering for the Queen site is that we are a pretty big user of electricity, and actually once the critical care units open and crit care draws a lot down, you know, we are going to need a new substation or transformer or various bits of infrastructure here, because we are running pretty hot And it is just worth thinking of all the implications of all this kind of stuff, you know. So I was been talking to Simon from the team, and Nick will know all this better than me, you know. But I was really intrigued to hear this when I was saying, why can we get more chargers in? Can we get more points in? Saying, well, that'll involve us increasing the amount of electricity and power usage we have here. So, you know, this all goes back to the anchor thing. It's also closely intertwined into people's work and life patterns and how they come in here. This big load that we put, you know, it's right to use this load, but it's really interesting for us to think about the way in which estates is tied into our clinical models, is tied into the care we decide to go here, and that ties into the movement patterns of our staff and members of the public coming in. But I think it's brilliant that the team have pulled together such a superb piece of work here, and really great to have the board sort of full-throated endorsement for us as we take it forward.
Yeah, excellent, good. Thank you. You're welcome to join me on the bus to Romford Station anytime you like, Matthew, by the way.
I'll walk it, Jack.
Oh, burn from Matthew there to me. Right, let's move on then in that case. Emergency Preparedness, Resilience and Response, the Annual Assurance Report. Keith, are you presenting this?
Yes.
Lovely, thank you.
Chair, good afternoon. Thank you for your time. So just very briefly to update and provide assurance to the group that for the third year in a row we have progressed against our NHS England and improvement requirements on EPRR and the core standards. We have only 3 against the current number of standards. We only have 3 outstanding that are well in progress for in my aim to be fully compliant next year. On top of the core standards, although they're currently reduced based on previous years, we're still fully aware of those that have been taken off and are keeping those in mind and working towards those that we're not currently being measured against as we can, and to enhance even more where it's about culture and embedding. So we have a full training, testing and exercising calendar for this calendar year to fully embed those elements as we need. So hopefully the detail is in the report, but I'm happy to take any questions or suggestions. Are always welcome. Or any thoughts?
Thank you. We have learned a lot about emergency preparedness and resilience over the last 2 years, I think it would be fair to say.
So have we.
I hope we have. Good, okay, thank you for that, Keith. Let's move on to the corporate governance section. Report from the Audit and Risk Committee, Sue.
Thank you, Chair. I will take the report as read. We've met once since the last board meeting. We met just before Christmas. The highlights I would like to draw the board's attention to are ongoing discussions with our external auditors about preparing for our next audit, and the learning from last time, which was their first audit, was the first audit in COVID, etc., etc. There's been significant progress with planning already undertaken. An interim audit is planned for February, whereas last year they did no interim audit and didn't actually start with us until after the year end. So I feel that we are significantly ahead of the curve in terms of planning and engagement. We also sought reassurance that we would have continuity of staffing so that the lessons learnt and the relationships established last time would continue. And we were given those reassurances. Finally, we sought reassurances about physical attendance where required, and that would be at a higher level. I have to say that conversation was before the full extent of Omicron, but I'm still confident that we'll be able to achieve a greater joined-uppedness than we did this time last year. So good progress in that regard. We also spent some time looking at the recommendations that the external auditors gave us, which in the main related to documentation and governance and arrangements around the PFI. That is an ongoing piece of work, and we have asked for further reports back to the Audit Committee, very specifically about how governance at the highest levels will be delivered to us on the PFI. We did have an interim presentation on the charitable funds audit. That will have to come to a future extraordinary audit committee date to be scheduled so that it can be approved by the board before the end of January. So that's a work in progress, but good progress as I understand it from George, and we are nearly there. Internal audit, we received 3 reports. 2 had significant assurance, which is great. 1 on urgent and emergency care improvement received partial assurance. It is consistent with everything we know about emergency care, and just adds to that array of data and the work that we're doing. Counter fraud has improved the way it reports with a much more refined dashboard, which makes it more transparent and accessible. So I'm really pleased to see that. Good report from health and safety, and I'd like specifically to draw attention to the report we received on the management of mortuary security risks. That was in the light of a letter issued to all NHS bodies, and we received strong assurance about how access and security is controlled and managed in this trust. I think that's all I'd like to highlight. I'm happy to take questions along with colleagues. Thank you very much.
Thank you, Sue. I don't see any questions on that. So thank you. Thank you for the work of the committee. Also, let's move on then to the use of the trust seal. You have a report on that, just so that we've noted the circumstances in which it's being used. Everybody happy? Yes, good. Risks identified during the meeting. We've obviously had a sort of theme and an important discussion and conversation about the challenges of staff vaccination, the action that's being taken, the potential impact on staffing from that, and board approval of the approach that's being taken, particularly in terms of encouraging staff whilst recognising concerns. We talked about the some of the issues around the quality of data for the board and assurance, and we now have some work in train to support that. And clearly, we've recognised the pressure on our performance and on our staff from the growth in COVID cases, on top of what would be a difficult time of year anyway. All of those things, I think, are properly represented in the board assurance framework and in future agenda items. Matthew, do you have something else?
No, all I was going to offer, Chair, was to do the board perhaps a short update at the end of next week on the vaccination status. I'm just conscious it's very much a moving picture, and I think it's probably something we need to update you on outside the cycle of usual board assurance, given the potential impact.
That would be great. Thank you, Matthew. I think that would be good for the board to hear. Great. Anybody else got anything else that they think we've identified before I move on to offering the opportunity for members of the public to ask questions in the 14 minutes that we have left? No? Okay. Are there any questions that anybody else outside the board would now like to ask? This is your opportunity. I'm giving a moment in case people can't find their hands. Okay, fine. We don't seem to have any questions that people want to ask during the course of this meeting. So thank you very much, everybody, for your contribution. We will, those of us on the board who will be attending the private board, you've got, we will start that at the time that we've agreed, which is 3:15. So you have time to get a quick cuppa and prepare yourself for 3:15, and I'll see you back here then. Thanks everybody for the quality of the papers and the discussion today. Thank you very much.
Thank you.
Bye. Thank you.